online MS Symposium. And first of all, I would like to acknowledge the traditional owners of the lands we meet. For me, that's Canberra, so the Ngunnawal people, and pay my respect to their leaders, past, present, and emerging. Before we jump into an update on our OHIOH project, just a bit of housekeeping. So you've seen the slides before, so this is our committee, and today I would like to take the opportunity to in particular thank Joe for having dealt so nicely all through the week with the facilitation of these meetings, and Toby, who is doing a lot of work in the background to make this possible. Yeah, so we are at the end of this. Just a bit of housekeeping. Yes, you all know, please leave your microphones on mute, and hopefully we have a little bit of time at the end of the session to ask questions. You know the drill, just type your questions in the chat box. Direct them please to everybody, and if you don't want to do that, just direct them directly to me so I can give them to the speakers. This session is going to be recorded, but we won't record the Q&A session. Okay, so today is all about our health in our hands, and you heard about this over the last few years. So this is a very interdisciplinary project funded by the ANU, and it aims to personalize medical technologies and sustainable and effective healthcare. It's a big words, but basically what our mission is to do a deep personalization of medicine and health management. And we're doing this by including a variety of data and do this in co-design across sectors, so across our disciplines, as well as with including people with lived experience. And yes, the aim is to have a personalized management of health as well as the data management. And we have two diseases we're working with, or two conditions. One is MS and the other one is type 1 diabetes. And I thought I'd show you a little bit of an overview to put some faces to this. So OHIOH is organized in 4 different programs. So we have genomics, big data, biomarker discovery, and health experience, as well as the 2 cohorts for the 2 conditions we're looking at, MS and diabetes. And we have the leads of these different streams here as pictures. And today we will hear especially from Hannah, who is the lead in the big data program, and 2 specific projects in this, presented by Deb and Robin, and from Jane, who is the lead in the health experience project. And then Joe will talk about what we're doing in particularly in the MS cohort. And we have a special guest, David, who will talk about his recent grant from MS Research Australia and how he fits into this whole scheme. And without further ado, we're jumping right in. So the first presenter is Hannah. And Hannah can't be here today, but she sent a video, which I will try to play now.
Good morning. I'm Associate Professor Hannah Suominen. As Anne already kindly introduced, I'm the leader of the OHIOH Big Data Program, and we interact with not only the MS cohort, but also the diabetes cohort of OHIOH and all of the research programs. You may have met some of us already in the MS Symposium last year, so we are quite a sizable team. We have had some students already finish their studies, like Max and Mejika, and new people joining the program, like Nicola and Liza. Our goal is to identify disease subtypes, predict how the treatment of the condition is going, and improve the accuracy and reliability of being able to understand how the disease is most likely going to develop in the future. This all is towards improved disease monitoring and patient outcomes. And our third equally important goal is to build trustworthiness into the system. In essence, we are talking about medical machine learning, and this development starts all from the cohort, so MS cohort here. We co-design, co-develop, and co-evaluate the methods. So we interact with people living with MS, as well as scientists, healthcare professionals, and policymakers in order to design the technology to be developed. After that, we integrate longitudinal, so time series data a long time, from multiple sources. So some is genetic, some phenotypical, some coming from new novel sensors, tablet computers, wearable sensors, smartphones, and so on. We integrate these data, and after that, with this rich source of data by combining signal processing, machine learning, natural language processing, and computer vision, so all of the data modalities, we try to support judgment and decision making through, for example, information visualizations, and in that way support information systems in healthcare. These technologies are connected to the internet, so we talk about networked information systems that have both a physical side, such as a tablet computer or a smartphone, as well as a virtual or cyber side, such as the data analytics platform. And this virtual circle of collaboration then comes back to the MS cohort, and together we are evaluating and reusing the data and devices that have been developed, and then we can again improve. Some of the successful platforms that we have been developing so far are a web-based portal where us researchers can advertise our studies that are recruiting participants, and then interested participants can register their interest and start interacting with us. This portal has been piloted and used for the COVID-19 case in Canberra already. And our platforms for machine learning, they are hosted, some of them here in Canberra, on Gaudi, which is our new exciting supercomputer. We have had some successful pilot projects already, such as one with Conan Medical to build a device that can test response time as well as scan the eye and look MS markers from there, as well as literally putting our health in our hands with a technology on a smartphone or tablet or laptop. It says say into the microphone, and our analytics is able to define quite accurately from data that a neurologist cannot hear, so human ear cannot hear this, if a person is having a given neurological condition or not, or at least is in the risk of having this one. I will stop here and thank you with this beautiful poem by Dr. Mark Nepo that resonates quite nicely with the text mining, data mining process to discover new insight from data. And I will let Deb and Robin to tell more about our exciting work. Thank you so much.
So Deb, can I ask you to continue and introduce yourself with a few words and share your screen, please?
Sure, I'll just unmute myself. So hi everyone, I'm Deborah and I'm from the Big Data stream of Ohio, but I'm actually currently located in Armidale at the University of New England. So I'm going to talk a little bit more specifically about some of the things that Hannah mentioned. I'll just share my screen now. So just one, share, and then I'll, so can you all see that? Can everyone see the slides?
Yep.
Cool, cool, great. Okay, so what I'm going to talk about today is some possible alternatives to MRI for diagnosing, tracking and predicting multiple sclerosis. And these are just on the right here are our partners, so the ACT Health, the Primary Health Network from Hunter, New England and Central Coast, and of course Ohio, and the ANU and University of New England. So as Hannah said, this is a very multidisciplinary program. My main area is signal processing, and I'm actually from psychology, so I'm also interested in cognition, thinking, you know, how our brains process information. So I'm just gonna, okay, so in as any of you who have multiple sclerosis will know, one of your main things that you've got to do is you've got to have an MRI every year or so, and that's one of the ways that the progression of your disease is tracked. So your doctor will tell you how many white matter lesions you have, and this is just a picture from a paper of a single patient over several years, and you can see the white matter progressing, the white matter lesions progressing over the years. And so that's the gold standard for diagnosis and tracking, and it's pretty good, but it's not always the best for people with MS, because obviously you have to have it, but it's expensive, and it's not very accessible. So if you live in the country like I do, and like many of our local patients do, you've got to travel to Sydney usually to get your MRI and to see your neurologist. So that makes it not very accessible. And I didn't really realise and that's only Armidale. What if you live out at Dubbo or Lightning Ridge or something like that? It makes it even harder. The other thing is there's some variability in the images if they're taken on different machines. So it's not always super reliable unless you're always having it on the same machine. And the other main thing is it doesn't really capture the day-to-day fluctuations, as I'm sure you all know. Then you feel better one day or 1 month from different months, and that's not really predicted by the white matter lesions. So what else could we possibly do? So, and I'm sure some of you have done some different tests, and I'm just going to talk about some of the things that we're currently doing. So one of the things I'm super interested in is postural sway, where you stand on a force plate. It's basically like a fancy set of scales, and this device measures how much you're swaying. And we've just actually published a paper on this. So this is a systematic review of all papers looking at postural sway actually in Parkinson's disease, but it's also affected in MS. And one of the things we'd be interested to do is be able to differentiate between different disorders by looking at postural sway. So that's just one measure that we're looking at. Another one is EEG, so that's electroencephalograms. So that is actually, you put a little cap on a person's head and you measure their brain waves. It's just electrical activity in the brain. And this is actually from a paper that a student of mine published about Huntington's disease, but these brain waves are also affected in MS. So this is where you're just preparing to press a button. And the red are the controls, and you can see that, and Robin will talk a little bit more about this as well. So it also happens to be affected in Parkinson's disease, and that will be interesting to look at in MS as well. This is quite a portable and much cheaper technology than MRI. Another really accessible and cheap measure would be finger tapping. So I don't know if any of you have done a finger tapping test, but one of the things that's affected in MS is motor control and processing speed. So one of our students, Mahika, made a little app where you can tap with your finger on an Android phone, and it will measure the time and the rhythm of the taps, and also how strong you are in tapping. So this is just a picture of the app that she made. So that's a possibility that could be done remotely, so you wouldn't even need someone to be there to test you. The last thing I'm going to talk about quickly is cognitive testing. So as many of you will know, it's quite common to have cognitive issues in MS. More than 70%, or approximately 70% of people suffer some kind of issue with their thinking, and that can vary from day to day as well. So you'll have things like processing speed, how fast you are at thinking, having complex attention, so attending to more than one thing at once, and episodic memory, so you might forget things. This actually differs between primary, progressive, and secondary. So that's one thing that could be differentiating between those two disorders by tracking people across time and seeing how that's affected. And it could also predict symptom progression. So could you combine this with other measures to have a look at how the whole picture is going. In the future, so in addition to the postural sway measures, in the future, we might be able to use wearable sensors. So these are actually already being used in Parkinson's disease. And you don't have to have all of them, but there's just a little device that you can have, and you can stick it on a belt, and then you could actually track people across the day. And this is a really interesting possibility for the future. So all of this stuff we're yet to do in MS, but one of the exciting things that I've recently got some funding for is to actually get a custom-made caravan, and we can travel around regional rural Australia. This is mainly for Parkinson's at the moment, but we're hoping to extend that to MS as well. And we can do all these measures right in people's own hometowns, and we can come back every 6 months or so and track them across time. And we're very excited about the possibility that this is going to offer for rural and regional Australians. So, and the last thing, and this is where I hook into the big data, is that we can then combine all these measures and do some machine learning and work out which of them is the most effective at tracking and predicting the progression of MS. So in the future, we're looking to combine these sources, find out which is the most informative, which combination is the most informative. So it could be that you could just do everything with finger tapping and cognitive testing, then you wouldn't need your fancy EEG machine. And the next thing to do would be to translate that into a practical clinical measure that people can do in the clinic, and possibly to do some remote diagnosis or tracking so that we can actually be tracking people, say, once a month or so, instead of waiting until your yearly MRI. So I'd like to thank Hannah in particular, also Christian Lueck from the ANU Medical School. We just published a paper together, and Max and Mahika, who've been our honours students at ANU, Wimbo, our fantastic PhD student, Robin, who's going to talk to you next, and the whole OHIOH Big Data team. So Robin's going to go into a bit more detail about those measures that I just talked to you about. Thank you so much.
Thank you, Deb. Robin, can you take over? And
hang on, I've just got to stop my share. Stop share.
Yes.
Yeah. Great.
Yes, of course.
Just tell us who you are and jump right in.
So hello everybody, my name is Robin Vlieger. I am a PhD candidate in the Big Data team, and I divide my time between the ANU, the Research School of Computer Science, and the Canberra Hospital. So I'll first zoom in a little bit. What I will be talking about today is two studies that we've been doing into people with Parkinson's disease and age and sex matched controls. The idea here was that we would identify objective measures of disease status. So what we're actually looking for is things in the data that can give us an idea of the disease status of a person. This both for diagnosis of a disease in the early stages, and also with a bit of luck, being able to track the disease over time. So why more objective measures? Well, there's of course a lot of variability. For example, in MS we have the EDSS, which is the standard tool, but we know that there's a lot of variability there. And in Parkinson's disease, we have the same thing with the UPDRS, which is basically equivalent of the EDSS in Parkinson's disease. And we know that there's a lot of variability there. So it would be good if we found more objective measures that give an indication of disease status. So our first experiment is a postural sway experiment, the experiment that Deborah was just talking about. This paper is actually published yesterday, so I think we can supply a link because it's open access. And if you would like to read more, then you can actually look at the paper. So what you see here is just me standing on a balance board on the Bertag force plate. And we do this experiment in two ways. We do it with the eyes open and the eyes closed, because the visual input will actually affect people's sway. What we do then is that we have these people stand on the force plate for a minute and a half, and we take consecutive segments of 20 seconds that we average to see the sway over time, give a good measure of that sway. So we look at different measures there. We look at the sway area, so actually the whole sway area that Deborah just showed, and we also look at the sway path and the standard deviation of the sway left to right and the sway forward and backward. What we also do with people is that we have them do cognitive tests and other clinical measures. So we have the Montreal Cognitive Assessment, the MoCA, which is the test that you see here on the side. Some people might be familiar with this. So you just do all these little tests here, and in the end, you get a score. And we have the NUCOG, which is another test. And then for the Parkinson's disease people, people with Parkinson's disease, we have the Parkinson's disease questionnaire, and then we have the UPDRS, which is the motor component of the standard test for the disease status. What we did then is that we looked at the sway path, first with the eyes open and with the eyes closed, both in the controls and in the people with Parkinson's disease. And you can see already that there's a difference there. People with Parkinson's disease with their eyes closed actually sway much more than people people without Parkinson's disease. And you also see that there's a difference when they have their eyes open and their eyes closed. What we did then was that we looked at the correlation between these the measures that we have from the actual sway experiment and the cognitive measures and the quality of life measures that that we took. And you can see there that there is a definite correlation between many of these tests. So here we have the UPDRS, the motor component, and we have the Parkinson's disease questionnaire here, the Montreal cognitive assessment, and then a verbal fluency test. And you see here that there's like a strong correlation between many of these tests. Now, the other experiment that we've been doing is a machine learning and contingent negative variation task. And basically what we do here is that we measure the electrical activity in somebody's brain. So I think people are pretty familiar probably with the picture of somebody having a cap on and like all these little electrodes being plugged in. And that is basically what we use to measure the electrical activity. So what we did in this task is that we had somebody look at a screen and there would be a blue square appearing. And after the blue square, there would be a time of 2.5 seconds in which nothing happens. But they were cued that after that, there would be a stimulus that they had to respond to. So if they saw an X, they had to press a button corresponding to the side of the screen. So if the X appeared on the left, you press the left button. If it appeared on the right, you press the right button. And if a Y appears, you had to withhold a response. So what happens there is that it's specifically about this time here, actually. So when people do that, you see the blue square appear, it enters the nervous system, and then you see that people in anticipation of the response that they have to go give to what's coming up, that there is like this response building here. And this is what we call the contingent negative variation. And as you could see in the experiment with Huntington's disease, we already knew that there is a difference between people with a neurological disease and people without. So we thought to replicate this experiment in people with Parkinson's disease, and later we will also do this in MS. So we measured this with 64 electrodes, and I'll quickly go over this, what we did in the data processing. So we've of course first had to clean up the data, so we filter it. We remove, for example, the eye blinks from the data and the muscle artifact, because of course we're measuring from the scalp. So if somebody moves their head or they blink or anything else happens, then the electrical activity from the muscles will also be picked up. So you have to filter that out. So then in the end, what we do is we have 90 trials and we average all these 90 trials to get a good view of what on average basically is the brain response. And then we use that to classify people with Parkinson's disease and controls to see if there's a difference between them. Now, in standard research into EEG, often what you see is that people will use a couple of electrodes and they will, for example, look at the peak, so a peak response, or they will look at the average response over time, something like that, or they'll look at the area under the curve here. There's all kinds of stuff that people do, but we weren't entirely sure which one would be the best measure. So in the end, I did a lot of different tests to see what would work best. And what we found was that you can take an average of the last time period here and an average around here when the, here, where the contingent negative variation starts to build, and then the difference would give a better overview of what was happening. And then we used a support vector machine algorithm, which is an algorithm which tries to divide these two groups with the biggest difference between them. And then you can basically say, well, we have one group here and one group there. And then with a bit of luck, you can actually make a prediction of somebody belongs to one group or the other. So when we did this, we found that we had 27 people that we could classify 11 people with Parkinson's correctly, and 4 people with Parkinson's were identified incorrectly. 4 of the controls were identified incorrectly, and 8 of the controls were classified correctly. What we did then was that we used more of a actual computer science approach to the data. This is called principal component analysis. And instead of just looking at averages of the electrode, of the 64 electrodes, what it does, it takes this data and it actually looks at components in the data, so of the 64 electrodes, and it will look at the components that actually best explain the variation between people in the experiment. And when we did this, and we took 8 of these components, because you rank them by how much variation they actually explain, we found out that this works wonderfully well. So here we had 14 people out of 15 being correctly classified, and 0 of them being classified incorrectly, only 1 control being incorrectly classified, and 12 of them being correctly classified. So we made a massive improvement here. So that's the research we've been up till now. Thank you.
Thank you, Robin. That was a really nice example of how machine learning can help us in analyzing data. So we now going to move over to the another stream of OHIOH we wanted to focus on today, and that's the health experience. So Jane, can I ask you to take over?
Yes,
just introduce yourself quickly. Yeah.
Yes, thank you. I'll get our presentation up. So hello everyone. My name's Jane Desborough. I lead the health experience team for OHIOH. The aim of our team is to embed the perspectives and experiences of people living with MS into every aspect of the OHIOH research. They bring critical context to study design, recruitment, data analysis, and knowledge translation, to name a few. The team, and sorry, I'll just, the team is comprised of 6 people living with MS, an MS nurse, 3 health services researchers, an ethicist and cybersecurity expert, and Dr. Anne Bruceley as lead of the MS cohort. And you can see our team here in the photo. We collaborate on every aspect of the work, which includes co-authoring papers and being investigators on grant applications. We meet every month and we work very closely on designing our studies and on working conducting group inductive analysis of the research. We largely conduct qualitative research. Our MS team members are remunerated for their time, although some decline this. We provide training as required to strengthen their capacity for meaningful collaboration. For example, we arranged for the ACT Healthcare Consumer Association to provide consumer advocacy training. We provided a 2-hour session on systematic reviews and data abstraction, and we all attended media training together. We have developed good relationships with the ACT MS community and some from regional New South Wales who are willing participants in the research. Many of these people have provided their names for ongoing participation, and most have enrolled in the cohort. We refer to them as our Brains Trust. We hope that our project can develop and support the next generation of researchers, including those living with MS. Janet Drew is one of our team members with MS who is doing her Masters of Philosophy, examining pathways of care for people with MS in the ACT. This year, during the COVID-19 pandemic, we conducted a study examining people with MS's experiences of using telehealth for healthcare consultations. And this research was presented at the 8th Joint ECTRIMS meeting in September. And I'll play this for you now.
My name is Katrina Chisholm, and I would like to introduce you to our MS Health Experience team that is made up of researchers, clinicians, and people like me who have MS.
Usual routine care is often neglected during pandemics. Our aim is to examine the experiences of people with MS accessing healthcare during the COVID-19 pandemic following the Australian government's expansion of subsidised telehealth consultations.
My name's Vanessa Zanning. I'm a person living with MS. We found that participants constantly assessed personal risk in their lives. They recognised that they were experts at managing risk and making decisions about their own health. Participants were aware that having MS made them more vulnerable if they were to contract COVID-19, and they had actively sought to stay informed.
My name is Janet Drew and I'm a person with MS. In response to COVID-19, some participants postponed usual care, concerned about exposure to COVID-19. It was also very challenging for participants having to decide whether to get treatments, such as an infusion of an immune-suppressing drug, in a hospital setting where they would interact with multiple people. Overall, participants were supportive of telehealth consultations during COVID-19 as they offered a safe and contact-free option. They also saw other positives, including better access, greater convenience, especially if transport is an issue or if fatigue flares up. However, some negatives were also raised about the telehealth consultation being less personal, being unable to read body language, and being unable to have a physical examination. Video consultations were thought to be better than telephone consultations as they enabled better communication.
My name is Marjorie and I have MS. To conclude, we learned that having telehealth consultations available is useful for providing care during the pandemic and beyond. While they cannot replace face-to-face consultations, particularly when physical examination is needed, telehealth consultations can offer convenience and greater access to healthcare professionals, enabling a safe and contact-free option for people with MS. Video consultations are preferred as they enable better communication. The pandemic has provided us with an opportunity to understand how telehealth is perceived by people with MS, which we hope can inform the future implementation of telehealth.
Okay, thank you. One of our pieces of work we have conducted was a metasynthesis of the qualitative literature examining people's experiences of living with MS, which is published in the journal Health Expectations. We were invited by the journal to submit an image for the cover of the issue that our article will be published in, which is will be published, we believe, this month or next month. You can see this image on the slide. The images were drawn by an artist to portray archetypes described by people living with MS involved in a workshop we conducted, exploring their experiences of engaging with researchers and clinicians. And the artist is Erin Walsh from our research school of population health. This workshop was the first of 4 that we used to develop an MS toolkit to support collaborative research between researchers and people with MS, which was funded by MS Research Australia. The toolkit includes materials to help people with MS and researchers understand each other and work well together. And this and the accompanying 6 filmed interviews between people with MS and researchers is available on the OHIOH website. We strongly encourage anyone working on OHIOH to become familiar with this toolkit. I will now play one of the interviews from the toolkit, and I'm going to practice my skills in changing what I'm sharing on the screen. So just bear with me for a moment. We've all become, we're getting good at these things, I hope. So, all right. So we asked people with MS and MS researchers to reflect together on how their values and priorities shape their approach to research. And in this video, they reflect on knowledge.
How do you respond to this? I believe that science and personal experience contribute to knowledge.
I believe that the science, you know, just even in the 17 years since I've been diagnosed, the knowledge and the science understanding of the factors that may or may not be contributing to the onset of MS and the progression of MS have changed enormously, has grown enormously. And I also believe that, you know, outside the scientific field, the ways that people have found to manage their MS symptoms or to modify their diet or whatever, have also increased the body of knowledge out there about it. So that if you're diagnosed in 2020, it's different than being diagnosed in the year 2000.
Yeah, I think it starts with personal experience, doesn't it? Because I mean, we wouldn't know anything about MS if people wouldn't have come to doctors or hospitals like these things are the things I'm experiencing, and it can be something that we can measure, or that can just be the things people tell us. But in the end, what researchers do and what doctors do, and basically what the whole medical field is doing, is based on these personal experiences. So I think it's very important because it's basically the starting point of everything.
But it's hard because scientists might not have that lived experience, so how will they be able to link it up together unless they actually work with that? Because most of the scientists that I work with, they don't know anything about it. For example, I didn't know anything about MS till I was working on this.
You know, if you think about MS research holistically, we do the ground roots biology. You can't ask a B cell a question. But you can certainly ask the person living with MS about their experiences. So that's why we need both in balance and in collaboration with each other. So absolutely.
Both has its merits, and we just need to make sure that we keep them separate and not taking like a one-off anecdote as scientific.
There's going to be enough variation across the participants, across the patients, the people with MS, that you have to consider the individuals as well. There's got to be some subjective information to help with the objective analysis.
There are some things that science cannot explain now.
Yes, that's what we hear, isn't it? I mean, there are things that we just don't know, so we need to research them, and I think that's the foundation of science, really, that there's things we don't know and we want to find out.
It seems to me that implicit within that statement, there's the idea or the expectation that in the long run, given enough time, science will be able to explain those things, but I believe that there may well be things that science never explains, because you answer one question, opens the door, asks another question, and it's sort of a chain effect.
The mistakes in science have come about from a hubris where science has assumed that perhaps we know a lot more than we do, and I think from what I understand, which is limited, I'll grant you, I fully acknowledge, but my limited knowledge is science seems to be doing the best job of demonstrating exactly how much we don't know as opposed to how much we do.
Okay. Great. Thank you, everyone, for listening to that, and thank you for our presentation, and we look forward to giving you more updates at the MS Symposium next year.
Thank you, Jane. Very engaging talk. These videos are also available on the OHIOH homepage, I believe. So if you want to have a closer look into this toolkit, you can go there and look at it.
If you look under partnership on the OHIOH website and then under partnership. Yeah.
Maybe Jane, can I ask you to put a link in the chat? That would be amazing.
Yes, I'll do that. Thank you.
So we are changing gear again, and the next speaker is David Sharkey. David, can you unmute yourself and introduce yourself?
Hi, thanks, Anna. I'm David Sharkey. I'm just going to share my screen now with my presentation. So I'm not a part of OHIOH, but I have the pleasure of recently receiving an incubator grant from MS Research Australia. Okay, is that good, Anna?
Perfect.
Great. Okay, so what I'd like to talk about today is the work that I'm doing, and it's about treatments. And look, I'd like to make a couple of points about treatments. Some of these points, I guess, I'm making for the MS researchers, and some of the points about my grant, I guess, are more for the people with MS. Okay, a lot of people here would know that I sit in both of those populations. Okay, so I should also say that I'm the head of the Department of Immunology Infectious Diseases here, so that means I have the great pleasure of sort of being Anna's manager or line manager, but she doesn't need any management. She does such a great job. Okay, so yeah, this is a quick talk about MS treatments and the things that I want to know about it. And I'll explain why all of these boxes are on this front slide in a minute. Okay, so just a couple of points. My number one point is that the medicine works. It really does. So even when I was diagnosed with MS, which is about 10 years ago, we knew that the various disease-modifying treatments that you could be prescribed would change the trajectory. It would change the number of relapses you had. But the real question out there was whether it would really change the long-term prospects for people with MS. We just didn't know that. And in fact, the view was probably it didn't, but it would make your life better with relapsing remitting MS. You'd have less relapses. Very recently, the data is now showing very clearly that getting on any of these treatments really improves your long-term outcome with MS. So without laboring these graphs at all, to show that there's two lines here, there's an orange line here, which is no treatment, and there's another line here for people who've had any of these treatments. And you can see that at any point in time, the people who've had these treatments are less likely to have progressed to secondary progressive MS. So that's the period in which disability starts to accrue progressively. It's the thing that for someone like me with relapsing remitting MS, I really don't want to see happen to me. Also, anecdotally, it's clear now that the operation of MS clinics is really different. So the number of people that are presenting over time, so they come to the clinic with a diagnosis, they get on a treatment, and then those people are walking back into the clinic 5 years later, 10 years later. And that's not the experience that we saw 10 years ago. And I have some sort of personal vibe with this as well, because my PhD supervisor was diagnosed with MS when he was in his early 40s, exactly the same age as I was, but this was back in the 90s. He didn't have any access to these treatments. His progression was far worse than mine has been. Now, MS is a highly variable disease, and I could be lucky and he could have been unlucky, but nonetheless, I think those two things really demonstrate the difference that we've seen. And in fact, when I've been speaking to neurologists recently, I say to them, you know, I was diagnosed with MS 10 years ago, I'm walking, I'm still working full time, I feel like I'm beating it, you know, I'm doing well. And they sometimes kind of crush that vibe by saying, look, everyone who was diagnosed when you were and who got on treatment are looking like you. And so I really want to make the point that treatment is important and it works. Okay, but the next point is that no matter which of these treatments you take, as Helena Paul, who was the MS nurse at MS in Canberra, told me, all these treatments have warts. None of them are great. So the reason why I showed all of those boxes before is because I've had every single one of those boxes. And so, you know, here's beta-ferron, wonderfully complicated, great for a scientist to fiddle with and put together, but it was horrible. It made me feel miserable. And I stopped that after about 9 months and I started Copaxone. This guy, you know, you've got to stick it into yourself, anyone who's done this. This is once a day intramuscular injection. You've got to move it around your body because it gives you massive big welts, at least for the first couple of years. Feels a bit like a bee sting, but, you know, I could deal with that because I didn't feel miserable every day. When Tecfidera came out, I thought, okay, I've had enough of needles. Let me give this one a go. But that one just made me feel crook in the guts and made me flush randomly during the day. I think I lasted, I stuck that out maybe 12 weeks, maybe a little bit more before going back to this one. I could deal with the needles and the soreness around me much more than just feeling rubbish every day. Fortunately, Copaxone went from every day to 3 times a week. That was fantastic because, you know, the needles were starting to pile up. And this is really, you know, this is what happens if you have to have Copaxone, the needles really pile up. The one thing about Copaxone that was most alarming is this thing here, which is an immediate post-injection reaction where you get this sudden rush, head flushes. It feels like you're blowing up like a balloon. Gets to a point, your heart's pounding, you're wondering, it's like a panic attack. I'd read about it, so I knew what was happening. I didn't freak out, I just lay down. And then it's like you get this huge deflation afterwards. And I felt cold, I felt shivery, I felt a bit ill. Sometimes I had a bit of diarrhea. So this would wipe out 2 hours of my day if I had one of these. We don't really know what causes it, but the sort of suspicion is that instead of getting a subcutaneous injection with it, which is what you're supposed to do, maybe you hit a vein and a bit of it goes into your bloodstream. Anyway, last year, there was a little bit of evidence for me of progression with some symptoms and on MRI. So I decided that I would go to Tysabri or natalizumab. I can't write for anything. Anyway, Tysabri, that's what that says. And that was all hunky-dory for about a year. But for those of you who know anything about Tysabri or natalizumab, you really don't want to acquire JC virus, which I'm going to talk about again in a minute. The other downside of Tysabri is here's me sitting in the Canberra hospital and you have to do that every 4 weeks. So that wipes out an hour, an afternoon every 4 weeks. Now, two weeks ago, because of JC virus, I moved to Ocrevus. And so here's me 2 weeks ago. In fact, I was listening to the MS thing on Wednesday back in the hospital, sitting in one of these chairs while I got my second dose of Ocrevus. Okay, right. So I just want to highlight now this problem of infections, because all of the really, really effective, the most effective treatments for MS, they mess up some part of your immune system one way or another. So, you know, this business of making a choice for the people with MS out there, you know what it's like. Every time you've got to make a choice about your treatment is you've got to talk to your neurologist, you've got to talk to people, what works for me? There's a whole lot of factors. You know, some are, you know, can I really, if I'm in a remote area, can I really, you know, go somewhere where I can have an infusion once every 4 weeks? Is that practical? You know, what about the other things that I'm doing? How do these things work with my lifestyle? It's really important. But for these most effective treatments, one of the other things to think about is that, as I say, they all compromise your immune system to a certain extent. And so I guess the really biggest example, and the one that I thought about most, was this thing, JC virus, which for some reason, if you are on Tysabri and you're JC virus positive, it's a virus that just sits in your body mostly all the time and you don't know, but it can go into your brain and cause this thing called PML, which has this horrible big name, and it's a horrible disease. It's slowly progressing over months, and some of the symptoms are even like MS, so it's just really tricky. So what you do is you test yourself every 6 months for JC virus. If you come up positive, you get off Tysabri, which is what I've just done. However, you know, JC is not the only thing. For all of the immunosuppressive treatments, whatever they do, whether they trap your white blood cells in lymph nodes, like Gilenya, whether it stops them getting into the brain, like natalizumab, or whether it just wipes out a whole population, like Ocrevus, there are other infections that can be a problem. So people can get an outbreak of shingles, bacterial lung infections can be a little bit more common. And if you're really unlucky, there's this thing, pneumocystis pneumoniae. So pneumocystis is kind of a fungal type infection in your lungs, right? So I got really interested in, because I'm a virologist, right? That's what I do, was like, okay, here's something I can contribute to be useful. Right, and so I'm really delighted that MS Research Australia funded my incubator grant, because if you're doing medical research, it's hard to change what you do. And what MS Research Australia does with this sort of grants is it will fund new ideas and it will fund new people like me. And you don't need preliminary data, you just need a great idea. So my grant is called this, Tracking Safety and Markers of Response to Cladribine Treatment. So you might be interested to know why I'm interested in cladribine when it's not a drug that I've chosen to take. Look, cladribine is one of these drugs that wipes out a lot of your white blood cells, but then they come back again. So the idea is you're trying to reboot the immune system to get rid of the white cells that are attacking your myelin and hopefully growing back ones that will then protect you. However, cladribine is interesting because it leaves you for a period very immunosuppressed until those things come back. So I'll explain a little bit why cladribine it was a good thing to use in our study, right? And so this is a study that was already set up, and it was set up by this team at the University of Sydney. Now, Simon Hawke is a neurologist. He works out at Orange. So here's a lot of people who are very keen on cladribine, because if you're living in Orange, you can't go and have natalizumab infusions or infusions, you know, every 4 weeks. As we were talking before, where you live really impacts on how you experience your disease, how you experience your MS, and the things that you can do for that. So he has a lot of people with MS who choose cladribine for that reason, because he practices out at Orange. However, because this study was set up, we're collecting a lot of other data with all of these samples. And the other thing that I really liked is that these are really close time points, and they're focusing on the area where people might be immunosuppressed with cladribine. So that's exactly what I want to look out for these infectious diseases. The other thing is that, again, there's multiple time points after you have a treatment. And in our study, we can look at not only whether there's telltale signs of infection that you wouldn't be able to see in the clinic, but the other thing we're interested in is if there's any markers of whether the disease is being stopped. All right. So the other part of the collaboration here is with Rory Bowden, who's at the Walter Eliza Hall Institute, and he's using cutting-edge RNA sequencing. Now, to make this a little bit more personal again, here's Rory and here's some other guy. And you can see that we haven't aged at all, but we worked and lived together. Actually, we didn't work together. We shared a house in Oxford back in the early 2000s. So you never know in science who you wind up with working again and whose expertise can become useful to you again, if that makes sense. Right, so this is a really great collaboration and brand new and only made possible through MS Research Australia. Okay, so what are we actually looking to do? We're interested in looking at RNA in the serum in blood in these samples. So just as a reminder for those people who don't think about this every day, our genetic information is in DNA, and the doing part of that information is turning it into proteins. And there's a message in the middle, which is called RNA. Now, this RNA also can be a virus, but we can detect this now with highly sensitive methods in serum. And the great thing about serum is that it can be from anywhere in the body, right? It's circulating around all the time. So pathogens can make RNA, and also cells release RNA. Some of this RNA is actually packaged in these little lipid things called microvesicles. Some of these are actually deliberately sent out from cells, but some of it's also free. Now, we've got some new methods that Rory has been working with at OHIOH, and they allow us to detect and then identify the source, because we're going to take this RNA and we're going to read the sequence. And we're also going to look at two different methods. One is more sensitive, but has less breadth. We kind of have to choose what we're going to look for. The other will be less sensitive, but we'll be able to look at absolutely everything. So part of the point of this is not only to look in this particular trial and to understand what's going on in those people with MS and in their response to cladribine, but we want to pioneer a method that we might be able to use more broadly to look at other treatments, or in fact, just to look at perhaps progress as a biomarker, like progress in MS. The idea is really, can we find some way of working out what's going on, people's risk of infection, for example, or whether a treatment is working before you have to go back to the neurologist, and we do all these non-specific things and we do MRIs, and it takes 6 months to find anything out. I really want to push that forward, again, because if you have certainty that the treatment that you are on is not doing you any harm and it is impacting your disease, it's easier to stay on that treatment. And we know that that's what you really need to do. Okay, so just to thank everyone here, apart from the people involved in here, here's my long-suffering lab who have to put up with me every day. And thanks, Anna, for giving me a slot here. I really appreciate it.
Thanks, David. It was really, really insightful. And thanks for all the sharing of your personal journey. I know we're running a little bit out of time, but I really would like to give Joe the space now to tell us what we're actually doing with the ACT MS cohort. So Joe, can you...
Okay, thank you. We're good to go. Excellent. Well, thank you for the opportunity to present today. So I'm a research fellow and clinical psychologist at the Research Fellow Population Health and working in Ohio. And today I represent a large group of researchers, clinicians, people living with MS and other stakeholders, and I'd like to acknowledge them in their contribution to the work that I'm going to talk about today. So here is my research team, and I represent them all today and acknowledge them and thank them for all their work in the work that we do. So the first study I'm going to talk about is called Elevita, and it's a study related to MS fatigue or fatigue in MS. And this was the news article that we launched at the start of the study. And essentially we know that many people living with MS experience fatigue, and it really affects their quality of life. The person in this article that we interviewed spoke about how he had to retire early because of his MS-related fatigue. It really slowed him down. He couldn't plan for the day and he didn't have the mental energy that he once had. So Elevita is a study, it was supported by an incubator grant from MS Research Australia, which we're grateful for. And essentially it's a cognitive behavioural therapy study, so CBT. It was designed by researchers in Germany, and they run it as a randomised control trial and got some really great results. So they translated it into English. So we're the first lucky people to trial this Elevita program in the English language. So we wanted to evaluate the acceptability and feasibility of the English version of Elevita. And once we've done that in a pilot study, we want to optimise it and hopefully use it as a randomised control trial in a larger study in Australia. So here are the hypotheses. So we want to see if it's acceptable, feasible and helpful, if people recommend it. And also we want to look if participants show an improvement in fatigue levels from baseline to post-intervention. So we have 15 people in the study, and some people, you know, we're really thankful for all of our participants. So 13 of them have finished the study and we're just waiting for the final 2. We'll certainly give updates on this study once we have all the data in. So essentially we were looking for people over 18 who had good English, had at least mild fatigue and good cognitive functioning and some mobility. We measured their fatigue before and after the intervention. And essentially what they had to do was listen to or participate in the program and do what we call the think aloud protocol. So it is what it sounds like. People just say out loud what they're thinking about the protocol. It might be related to the content or the activities. It might be related to how they relate to the material. They also reflect on their own conditions and their own fatigue. So it's been really interesting listening to people think out aloud as they do the program. And we're also looking at quantitative data. So how much, how they participate in the program, they engage, and their feedback and how they rate the program. So the content, I'm a clinical psychologist and very familiar with cognitive behavioural therapy, and it's a standardised approach. So there's 9 conversations that last for about 1 hour each, and they cover these topics here. So sleep, exercise, mindfulness, managing thought patterns, having different types of logs, coping with stress, managing emotions, again, thinking styles and alternative thoughts, support networks, and how to goal set. So very standardized approach to the program here. One thing I really like about the program are these animations that depict managing fatigue. So stay tuned. We'll certainly give you an update once we have all that in the next few months. So that's one of the studies I wanted to talk about, and the last study I wanted to talk to you about today is the ACT MS cohort study. So it's a longitudinal study, and it's unique in that we're involving adults both living with MS and without MS. So there are longitudinal studies related to MS in Australia, but this is the first one that has both those 2 cohorts together. So we're looking for people with and without MS because it's easy to attribute everything to MS when you have MS. So what we're looking for is people without MS to see what the differences are. Are the things happening related to aging, or are they related to MS, or are they related to other factors? So we want to better understand how all these factors impact the health and well-being of people living with multiple sclerosis. So essentially, if you're interested, you do an initial appointment that you would do the patient information sheet and the consent form and then a questionnaire. And then we have a baseline appointment for people living with MS. That's within about 1 month of having a doctor's appointment or an MRI. And then you do a health and medical questionnaire. So because of COVID, we're actually doing a telephone EDSS rather than a face-to-face EDSS, and all of our interactions are actually online or over the phone at the moment. For people with MS, if they have a relapse, we'd like them to let us know so that we can just collect more information at that time or close to that time. And essentially people without MS, it's just having that initial appointment and then a baseline appointment and then every 12 months following that. We've also asked people involved in the cohort study if they'd like to be told about other studies within Ohio, and then we can connect them to them if they'd like to do those. So at the moment we have 14 people living with MS who have registered in the cohort study. We don't have anyone at this stage without MS, so we're starting to recruit people without MS, and we're thinking people who have an interest in an MS will probably be the ones who will get involved, so family or friends or researchers, for example. So can you help? There's the website on the Ohio website, and there's lots more information. And you can contact the ACTMS cohort study email address there, or you can contact me and certainly look up the website there. So thank you for letting me present today. It's sorry we're running a little bit late. And Anne and I have both been really thrilled to coordinate this whole symposium. So I'm going to steal Anne's thunder and just say thank you so much. We'd love to get your feedback. So there's the email address there, mssymposium@anu.edu.au. If you'd like to give us any feedback on the symposium or any ways we can improve for next year, that'd be really appreciated. So I'll stop sharing so we can see all your beautiful faces. Thank you.
Thanks, Jo, and thanks to all the speakers. It was, I think, terrific to see all these different aspects of Ohio and what's going on in the research space. And thank you all who are participating and who have been here every single day of the week. I see lots of names over and over again, and I'm really appreciative of that. So I hope you enjoyed our journey through together. So just as a recap, so we talked about inflammation and brain health, brain aging. We talked about diet and the microbiome, and then we had talks on exercise and vitamin D, then a really interesting symposium, a panel discussion, and then today the Ohio update. And as Jo just said, we can't do our research without you. So we really, really would like you to contribute and work with us. So please check out the site and yeah, stay in touch. And yeah, thanks again for participating to everybody. I don't think we're gonna do a Q&A, we're already over time, but if you have burning questions, just send them to us and we will make sure that we can answer them. And yeah, with that, thank you and hope to see you all soon. Bye.